Thank you, Susan. Marc, your bio is the longest, and I'll shorten it so you get 30 seconds extra. Okay. So Dr. Marc Michalsky is a professor of clinical surgery and pediatrics at the Ohio State University College of Medicine, where he serves as the surgical director for the Center for Healthy Weight and Nutrition at Nationwide Children's Hospital in Columbus, Ohio. Under his leadership, the Center's Adolescent Bariatric Surgery Program has become both nationally and internationally recognized for its clinical excellence and its participation in research, some of which he'll be presenting today. In August 2015, the Bariatric Surgery Program at Nationwide Children's earned the distinction as the first freestanding pediatric center in the US to be awarded clinical accreditation. Marc serves on multiple national boards in the area of pediatric bariatric surgery.
Great, thank you very much, and thank you for the great invitation to come present. And I just have to say, sitting next to Susan, it's not only multidisciplinary, but I think institutional collaboration is great. And for the Big Ten football fans in the room, it would not be lost that I'm a Buckeye and she's a Wolverine. But I am proud to say that my oldest is starting his studies in Ann Arbor in the fall, so we're going to be honorary Wolverines for a while. I'm going to just give you a brief overview. I'm not going to spend a lot of time going back through some of what you've already heard about bariatric surgery and some of the physiologic explanations of how it works. I have nothing to disclose. I'm happy to say that I apparently have the right slide because I think this was the first slide we saw this morning. And I think this is a very important bit of data in terms of some of the cross-sectional analysis that I think, if nothing else, speaks to the fact that we really do have a critical issue here in terms of the prevalence of obesity. And yes, to acknowledge some of the data that has shown a plateau or a leveling off. Certainly, there is corresponding data that suggests that within the adolescent time period, that is not the case. You can see here, and again, Dr. Nelly has spoken to some of the prevalence issues here, specifically looking at the adolescent prevalence of severe obesity as high as 9%, which is obviously quite striking. We've seen this number just recently, 5 to 6 million children overall are considered to be categorized as being severely obese, and we've heard also about the very, very low procedural prevalence of bariatric surgery. We do know, again, from a number of cross-sectional studies that severely obese children tend to become severely obese adults, and that the risk for that increases as children transition from preteens to teens and then ultimately into early adulthood. And all of this, I think, speaks to and supports the paradigm of at least considering bariatric surgery as an effective treatment modality for this particular subpopulation of the obese group. Again, and this is really relatively hot off the press, large cross-sectional data looking at the comorbid impact. And we've already heard a little bit about some of the comorbid conditions, but certainly cardiovascular risk seems to be quite prevalent when you're going up in the various categories of obesity. And this is a recent paper from Israel, again tracking the rates of adult morbidity mortality from a group of individuals that were tracked during their teenage years. And strikingly, you can see that individuals that are at the 95th percentile or greater for BMI have a 3.5-fold increase in their adult cardiovascular risk mortality. So quite striking. But I think what's also really eye-opening here is that when you go back down lower than the 95th percentile, there again seems to be a graded increase in risk amongst individuals in the 50th to 74th percentile. And these are percentile ranges that we consider normal or, make us feel reassured that we're not in the danger zone yet. However, data like this, I think, if nothing else, suggests that we should really be relooking at that. as a potential issue. Corresponding data from this group has also shown increased risk in mortality related to diabetes. And again, I think that in combination with some of the other slides I've shown you and the other data that's out there, this certainly supports the imperative to deliver a effective means of losing weight in this population. And finally, I think that things like this have truly influenced the ongoing and expanding interest in bariatric surgery in the pediatric population. Teen Labs, which you've heard a little bit about, and in full disclosure, is actually an ancillary study from the Labs consortium chaired by Tom Inge, who many of you probably know, who recently left from Cincinnati, is now based at Children's Hospital of Colorado, is a prospective observational study designed very much in parallel with the Labs consortium. And you can see here, going back to some of the comorbid conditions, that certainly very, very high prevalence. These are children or teenagers that were about to undergo bariatric surgery as part of this study. Very high prevalence of dyslipidemia, sleep apnea, joint pain, hypertension, so on and so forth. In addition, you can see there's actually a multiplicity of comorbid illness that exists along with being severely obese. So more than 50% of the population had more than 3 related comorbid conditions. So very striking, along with other markers, biomarkers of cardiovascular risk, including elevated CRP, hyperinsulinemia, low HDL, and elevated triglycerides. And also, very similar to some of the tracking data from Labs, a surprisingly prevalent degree of renal insufficiency. So again, some very, very serious components that are associated with this level of severe obesity. Without getting into a lot of the details, I think this slide just really says it all. This is from our recently published 3-year longitudinal data, and you can see on the left side of the screen, this is follow-up from our 3-year data set showing significant reduction in weight over time. The 2 procedures that are being displayed here are Roux-en-Y gastric bypass and sleeve gastrectomy. But really, the panel on the right, I think, really drives the message home in terms of remission rates. So a 90% remission rate among individuals in this study that were diagnosed as having type 2 diabetes, 77% remission of the pre-diabetic state, 66% remission of dyslipidemia, and so on and so forth, improvement in elevated blood pressure and abnormal kidney function. So, you know, I find it important to stress again and again that it's not just about anthropomorphic change, but rather metabolic health that changes after these operations. And again, in full disclosure, as Bruce mentioned a little while ago, obviously there are complications and risks associated with these. Certainly, without getting into all of that, the risks that we are very, very concerned about are micronutrient and macronutrient deficiencies. You can see here that there are significant reductions in ferritin level, as well as vitamin A and vitamin B12. And I think this just speaks to the importance of being able to remain engaged with these patients long-term to make sure that this is being followed and that these individuals don't get into trouble. From a consensus standpoint, what's the national discussion? This has changed over time. Starting in 2004, Tom Inge's article that was published in Pediatrics, I think really took a bit of a more conservative approach to eligibility based on BMI, which was an extrapolation of the original NIH consensus. That has changed since then in later years or over the following decade through ASMBS, and a collection of thought leaders and consensus has been developed, as well as through work done by the Children's Hospital Association, Focus on a Fitter Future, which several people in the room have been participants in. And now we have eligibility criteria that is somewhat, again, similar but not identical to the adult criteria, where we look at BMI of 35 or greater, or class 2 obesity or higher, along with a number of different categorizations of comorbid diseases as being defined. Again, in the pediatric population, we're sensitive to other issues, including Tanner staging, skeletal maturity, and the support system around the individual patient to decide if a patient is actually a good candidate and an appropriate, for an appropriate operation. And then finally, in terms of other forms and structure, in 2014, the Adolescent Bariatric Surgery Designation, Center Designation, was adopted by the joint American College of Surgeons and ASMBS MBSA QIP program, which is the metabolic and bariatric surgery quality assurance program, which is national accreditation, which again Bruce has touched on. So now we actually have a number, quite a few actual centers in the U.S. that are specifically designated as places where adolescent patients can receive bariatric care. Again, just to wrap up here in the last couple of seconds, I think really the issue here is access and attitudes and what we are doing to make these types of therapeutic interventions available. Certainly, there is a plateau in the last few years of bariatric surgery. You can see that in the early 2000s, up to 2006, 2007, the procedural prevalence increased, but there's really been a leveling off since about that time over the last decade. So there is more and more evidence that bariatric surgery for the pediatric population is good, but somehow or another it doesn't seem to be reflected in increased prevalence rates over the last decade or so. And I think there are challenges also in terms of insurance. This is a study of the Teen Labs cohort that we enrolled, and looking here, we can see some interesting issues. If you compare to the adult population, where a bariatric surgery approval rate, assuming that a patient has insurance where bariatric surgery is a covered benefit, success is upwards of about 85%. In the pediatric world, it's only about 47% based on this cohort analysis, looking at application the first time. Interestingly, if you look at this cohort, there are some other discrepancies between private and public insurance. And in addition, 80% of denials ultimately in our pediatric group wind up having been approved, but after as many as 5 appeals. Can you imagine trying to tell a family that you have to appeal up to 5 times? Needless to say, the dropout rate after the first or second or third rejection is quite remarkable. So there are some real disparities here that we need to get a handle of and figure out ways to deal with. And then, finally, the number one reason for rejection in this study was age less than 18 years of age. So, again, challenges. And then even professional challenges. Susan published a great paper a few years ago surveying pediatricians and family practitioners looking at attitudes towards referrals and whether or not a practice would be willing to actually go ahead and refer. And interestingly enough, 48% of those surveyed said they would never refer a patient for a adolescent bariatric procedure. Again, these are challenges that we are really needing to work on and continue to do so. Again, 46% endorse a minimal age in this survey of 18 years of age or greater. So interesting correlation with the insurance data that I just showed you. And then finally, 99% of that survey endorsed participation in monitoring weight management program prior to referral to weight loss surgery, which seems to make sense. So in conclusion, and to wrap up, there's an ongoing delivery of high-quality data that supports the use of weight loss surgery in the pediatric population. Consensus-driven best practice guidelines and national accreditation standards have been established and currently seem to be working well. Procedural prevalence, as I've mentioned, has remained relatively stable despite these favorable outcomes and standardization of care. Access to care is limited by several variables, some of which I've touched on here, and efforts should be undertaken to increase both public and professional awareness related to this treatment modality as an effective means to help our patients. Thank you very much.